Hello and welcome everyone. Today we'll be discussing about chest tube management in the ICU, what you actually have never read in the books. So what exactly is pleural drainage? It is a process of inserting a chest tube, that is a thoracostomy tube, into the pleural space, that is the area between the lungs and the chest wall, that is the two pleural walls. The purpose is to remove any air, fluid or pus or blood in this particular place. The visceral and the parietal pleura, they form what is known as the pleural cavity. So it is used to remove the pleural effusion, empyema, that is pus, hemothorax, that is blood, or pneumothorax, that is air. So how this has evolved over time? In ancient times, Hippocrates first described pleural drainage using hollow reeds to drain empyema. In 19th century, before the antibiotics, infections inside the chest were treated surgically with open drainage. The problem was opening the chest often caused the lungs to collapse unless the lung was stuck to the chest wall, or that is, there is some kind of a pleural adhesion. In 1871, William Fairplay introduced the subcutaneous drainage, a method to prevent air from entering while still draining the pus. In 75, Gotthard Bulau, that is a German, he designed a closed system using a siphon principle, reducing the infection risk further. In 20th century, there have been various breakthroughs, mainly during the World Wars. In the World War I, the high rates of empyema due to pneumonia in soldiers were seen. So Evans Graham from USA successfully treated empyema using a closed drainage system, which further reduced mortality. In World War II and Vietnam, the need for a quick and safe treatment of hemothorax and pneumothorax was looked into, and the introduction of plastic chest tubes, flexible and less prone to kinking, was initiated. Underwater seal drainage became a standard for trauma care. So we had something called the Hemlick's valve in 1968. It was introduced by Dr. Hemlick, the same person who had the Hemlick's maneuver. It's a one-way valve that lets air and fluid escape but prevents any backflow. It is portable, sterile, and allows the patient to walk around, unlike the heavy underwater bottles that you have seen in the photographs. So the chest tubes and the types of its usage. The material, it is made from PVC or silicone. It is flexible and biocompatible. The design variants are, various types are available. It can be straight, angled, spiral or pigtailed, that is coiled in the end. The design is based on the specific drainage needs that you have. You have something called plaque drains, which are multiple channels instead of one central hole. And you have a radio opaque stripe which is visible on X-ray to confirm its position. You have a sentinel hole marker which helps locate the proximal drain hole for the positioning that needs to be done, and double lumen tubes can be used for both drainage as well as fluid installations. The size is done by what we know as the French size. It is measured as the external circumference in millimeter multiplied by 3. So a 12 French means a 4 millimeter diameter external circumference tube is being used. So the size is classified as small bore, that is 8 to 14 French, which you use for pneumothorax, pleural effusion or empyema. It is less painful and easy to insert and has less complications. The next, you have a medium bore size, which is 16 to 24. It is used for moderate pleural effusion and patients who are having blood. The large bore is 28 to 36. It is for more thick fluid, that is a massive hemothorax or extremely thick empyema. It is more painful and definitely has higher risks, but it is necessary if you are dealing with a situation like that. And the insertion tip is avoid trocars if you are using these large bore cannulas. They can damage your blood vessels. Use blunt dissection for safe placement. Regarding the closed drainage units which we are currently using, the purpose is to drain the fluid and air. They prevent the reflux back in the pleural cavity. They restore the restore the negative pressure of the lung for re-expansion. The structure is that it is sterile and disposable device. It is placed below the chest level to use the gravity for the drainage, and it includes the one-way valve, that is the Heimlich's valve that we already read, or a water seal drain. So the types that we have for the drain are the one bottle system. This is for air drainage only, and it is not ideal for fluids because the fluid would build up and block the air from escaping. You have a two bottle system. The bottle one collects the fluid, the bottle two, the water seal to prevent the backflow. It is better for draining large volumes of fluid. The three bottle system, it adds a third bottle to add a suction. It is used for active suctioning is required. The modern units are all chamber combined in a single box. They have a smart tracker also in some modern devices. They check the flow of air and fluid through the tube. The pleural pressure also trends, and it is helpful for post-operative monitoring. Regarding the suction system and when and how to use it, why do we use it? First is because it helps when the gravity drainage isn't enough and you think some extra pressure can help. It aids in the re-expansion also. It stops the air leak in pneumothorax by pressing the pleurals together. So when to avoid this? You avoid this is immediately after insertion, especially in complete pneumothorax, young patients, deflated lung which is present for too long, because there is a chance of re-expansion pulmonary edema. How it works is that you use a water seal control, use the water column height to regulate the pressure. A 20 centimeter water height is equal to 20 centimeter suction pressure, negative 20 centimeter. So the pressure doesn't change even if the wall vacuum strength changes. So dry suctioning, it uses a dial to set the pressure, suction pressure. It is more modern and more convenient than this water seal suction that we are using. Still the suction couldn't exceed the set limit. So type of suction sources that you have the wall suction, that is the hospital based. It is strong but limits the mobility of the patient. Portable devices like battery and electric operated, they are good for ambulatory and home care, but they need regular maintenance. Mechanical ones, they ensure safe suctioning around 10 to 20 negative and placed between the wall suction and the CDU. Regarding the clinical application of this whole unit, pleural effusion, as we have already discussed before, the two types, that is transudative and exudative. So the fluid can be because of a systemic disease, that is heart failure, cirrhosis, nephrotic syndrome, or exudative like some kind of an infection or malignancy. Management is transudative is usually treated medically. You don't put chest drains. Chest tube is used only if it is very severe, resulting in breathlessness, refractory to all forms of treatment, recurrent despite the thoracocentesis, palliative relief in patients who are not fit for repeated procedures. Exudative, it requires diagnostic and therapeutic drainage, often needs pleurodesis for recurrent and malignant effusions. Pleurodesis is a procedure to glue the pleural layers together to prevent any recurrence of the fluid from accumulating. The two techniques are slurry, that is drug via the chest tube, or the porridge, that is the drug sprayed during the thoracoscopy. Common agents are talc, tetracycline, doxycycline, and bleomycin. Use more than 12 to 14 French for effective talc slurry. This was in the Time 1 trial. Complicated parapneumonic effusion or empyema. This is a complicated effusion which has loculated low pH to glucose ratio and high LDH. It has basically a frank pus. The stages are exudative, that is, it is still in free flow, treatable by this particular method. You have fibropurulent where it becomes very thick, so you need to put in large bore tubes. And finally, organizing, where you need VATS and thoracotomy. Treatment would be chest tube is essential here, intrapleural fibrinolytics to improve the drainage. LBCTs, that is, you use the large bore cannulas, that is around 20 to 28 for thick pus. Small ones may work if you are using the fibrinolytics. Surgical option is VATS and thoracoscopy. Decortication. Chemothorax, blood in the pleural cavity due to trauma, surgery, and vessel rupture. Indication for the drainage is volume more than 300 ml. or need for ventilation, inserting the chest tube. Immediate tube placement helps in evacuating the blood, re-expansion of the lung, detecting ongoing bleed. The tube size is large. Newer evidence is that you can put the 14 French pigtail, which may suffice in many cases. Surgical referral is needed if the drain is coming very large amounts, that is 1.5 liters, more than 200 per hour again if the blood is coming. For retained hemothorax, early VATS is better to remove the clots because it can prevent the fibrothorax from happening. Pneumothorax, the types you will get is the primary. No known lung disease is previously present, usually tall, thin young men. Secondary is due to underlying lung disease. Traumatic because of the damage. Tension is life-threatening types. So management is usually small. For the small PSPs, that is spontaneous, you just observe and needle aspirate. For the large, you put a chest tube, you will get a 90% success. Conservative approach is now supported by trials. Re-expansion is seen in 80% within 8 weeks. Regarding secondary, always need to put a chest tube, may require pleurodesis and surgery if it is prolonged air leak. Tension pneumothorax, emergency is first to insert a needle and then put the tube. Delay may be fatal. Modern options are portable air leak devices, allow outpatient management, improve mobility and reduce the hospital stay. So these are the various cases where you will use the chest tube, and the sizes are given and special instructions how to use them are given. Regarding how to do it, just go through a step-by-step guide. Always use imaging before inserting the tube unless it's an emergency, of course. So ultrasound is very, very vital and it's preferred over any other thing. Standard site would be 4th and 5th intercostal space, mid-axillary line, that is at the level of the male nipple, called the safe triangle. The safe triangle is bordered by the pectoralis major, latissimus dorsi and the nipple line. Alternative sites would be the 2nd and 3rd intercostal space, mid clavicular line for apical and tensor pneumothorax, but it is not preferred and it's also less cosmetic. Ultrasound guided freehand technique can be used. That is, you check the ultrasound and put it wherever you feel is the best. Mark site under the ultrasound and then put it. So there are no such restrictions of the site of the rib space. The technique is for the small bore tubes, insert using the Selzinger technique. It is pretty easy with using the guide wire, safe and more comfortable for the patients. So newer kits have varices needles which help in preventing lung damage. The large ones, that is more than 20, insert by blunt dissection, which is better. It is safer than the trocar technique because the trocar technique can cause vessel injury. Procedure tips: position the patient supine or lateral. Use sufficient local anesthetic, that is very important. Insert a needle over the upper rib edge to avoid the nerves and the vessels. This is very important, not the lower rib edge. Always go through the upper rib edge. Aspiration of the air and the fluid confirms entry into the pleural space. Secure and connect to the underwater seal for suction. Securing the tube, why it is important? Because it prevents the tube from falling out and reduces the risk of infection. Suture reduces accidental dislodging. Use silk 1 or 0 for large tubes and 0, 0 for these small tubes. Leave in place for at least 10 to 15 days post tube removal to close the site. The various techniques are available. The most common one is the Donati, that is horizontal mattress. You close it in the figure of 8 suture. The purse string, which is a circular stitches, are tightened around the tube. You have Roman sandal, which is cross lacing like a sandal for extra hold. You have other methods, that is balloon drains, which is inflated inside the pleural space like a Foley's catheter. Tube securement devices that sticks to the skin and reduce skin trauma. Adhesive dressings which add and support the infection barrier. Complications and management is important. The preventive measures is always use full sterile precaution, gloves, drapes and antiseptics. Train thoroughly in the anatomy, ultrasound usage, safe techniques, checklists and protocols to improve outcome and reduce errors. These are the various complications, that is tube malpositioning, infection, bleeding, organ injury, tube blockage, re-expansion, edema and tube dislodgement, and how to manage them is given over here. Regarding training, the step one is have the theoretical understanding, the indications, the contraindications, and the anatomy. Step two is do it in dummies, ultrasound, and virtual reality, simulation based techniques, then specialized clinical supervised during your clinical experience. Start with simple thoracostomies, get feedback from your seniors, then keep developing your skin, go to workshops, hand-on updates, video refreshers. The recent UK study found no respiratory trainee lacked skill and confidence. Training must be wider and standardized, so it is not restricted to only respiratory trainees. Regarding the summary, the chest tube thoracotomy remains the cornerstone to treat pleural diseases. Shift from large to small bore whenever appropriate because it is better. Use digital drainage system because they help in tracking the air leaks. Monitor pleural pressure in real time. Continuous learning and simulation is important. So to achieve a proper chest tube placement, you should learn the techniques and train. Gain ultrasound usage, use it for your guidance, choose the correct size tube, make a sterile field. Once you have inserted, secure the tube properly, avoid putting any kind of early suction, flush the tube in case of any cloggings, and finally, always evaluate for complication, monitor them, and address them. Thank you for your patience.